Hi, everyone. We'll get started with today's rounds. Today, we have Dr. Joan Sari. She's an occupational medicine specialist with a niche expertise in extreme environments. She also holds a PhD in medical science and an MSN in clinical psychology. She's the director of the Division of Occupational Medicine at the University of Toronto and past president of the Occupational Medicine Canada. In addition to working with Unity Health at Toronto St. Mike's Hospital, she oversees aerospace medicine, education initiatives at Temerity Faculty of Medicine, and serves as chair of aerospace medicine at the Royal College of Physicians and Surgeons of Canada. She is also a consultant with the Canadian Armed Forces and the Canadian Space Agency, and was named one of the top 25 women in defense. She is also a fellow of both ACOEM and ASMA, and has represented Canada internationally in both occupational and aerospace medicine roles. And today she's here to speak to us about migraines and safety-sensitive work from an evidence-based update. Welcome.
Thanks. We'll just do a comms check and see if you can hear me. I'm getting a bit of reverberation on my side. Oh, can't hear you, Kathy. Sorry.
I said, I think we have somebody who was off mute.
Oh, okay. But, oh, yes. Okay. It sounds better now. You can hear me okay, though?
Yes, I can.
Okay, great. Thanks for that introduction. And I'm going to bring to you a little bit of evidence that is derived from some of the work I was doing with the Canadian Forces in a literature review we did to specifically inform some aviation decisions, but since it's safety sensitive, it's applicable to a variety of safety sensitive environments. And to acknowledge Rosalind Mainland, who is an internal medicine resident at Queen's now, but at the time was a fourth-year medical student working with me to help with the project. So acknowledge all the effort she put into doing some of this literature review. Sorry, just checking the slides are going to move for me. There we are. So in terms of my affiliations, you already knew that I'm associated with the Canadian Armed Forces, this Canadian Space Agency. I'm associated with a small company called Aeromedical. And I really don't have any associations that would impact this talk, but I do want to make the disclosure and make it very clear. I'm not a neurologist. I'm an occupational medicine specialist. And so this comes from the perspective of an occupational specialist as opposed to a neurologist. So the goals of today's talk are, I'm going to talk to you a little bit about risk assessment because that's what's required in safety sensitive situations. And just give a brief refresher and hopefully provide you some useful resources for approaches to migraines, because there have been a few good publications I can bring your way. Identify the case history features that provide relevant information and just give you a background of the literature, and hope that your presumptions about risk and various characteristics of migraines match the evidence. We got a few surprises ourselves. So, and then we'll talk about safety sensitive workers. So to begin, this is a publication 2018 on the International Classification of Headache Disorders. The references, as much as possible, I've included on the slides there, which show you for part one, the primary headaches, and migraine is one of the four listed primary types of headaches, so not headache associated to trauma or concussion or anything else like a head injury like that. So what is a migraine? It's prevalent, and we'll talk about prevalence in the next few slides. Highly disabling in many cases. It's a primary headache disorder, as I just showed you. It's characterized by this neuronal hyperexcitability, and it manifestations is highly variable, really a range of accompanying symptoms that go with it. And it happens through the stimulation of the peripheral trigeminal afferent nerves that innervate the dura of the brain, large cerebral arteries, and then there's a release of these vasoactive neuropeptides, such as calcitonin gene-related peptide, and you may see some new discussion about treatment for migraine that relate to monoclonal antibodies against calcitonin gene-related peptide. So in terms of prevalence of migraine, most studies on migraine prevalence show this unimodal type of distribution by age, which show highest prevalences from age 25 to 44 in both males and females, with the peak around age 30 to 39. However, there is a prominent study that found a bimodal distribution of prevalence in males and females, which first peaking at 25, but then having a second peak at 50 for women, around 40 for men. So there's hypothesis about what that second peak was, suggested to be related to estrogen fluctuations in the perimenopausal period for females, and then the second peak in men proposed to be related to decrease in testosterone and free estradiol that occurs in middle life. But that's pretty speculative, but it is an interesting observation that was relevant for us in the aviation world, because there was some pre-assumption that you know, if you got through your teenage years and into your early 20s, you were okay, and that may not be the case. So we're watching time is time of onset in our populations. So what are the types of migraines? Migraine with aura, which is the classic migraine, has this aura preceding the headache and resolving with the onset of the headache. And then without aura is the common migraine. And then aura can occur without a headache, which is the aura alone, and then hemiparesis. So the big question for safety sensitive work is this headache that people are complaining of, if the person in front of you is a safety sensitive worker, is this a headache, or is it another type of primary headache? I'll show you this reference here, which I'll give you a list of references at the end of the talk if you want it, is a migraine screener. A simple way with a mnemonic pin: photophobia, impairment, functional impairment, and nausea. And if the answer is yes to 2 or more of those items, the screen is considered positive for migraine, with a positive predictive value of about 0.93. So that's the probability that a patient with positive test actually has the disease. So that's pretty simple and important. Wanted to just bring that in case you hadn't seen that paper. And then as well, is it a migraine, or is it under other underlying pathology? So that's part of the challenge also in safety sensitive work, is defining the actual diagnosis. There are red flags that we think about for mechanical back pain, and there are also these red flags for migraine. The acronym SNOOP4 is here in front of you, and it's the paper that it's derived from is also copied there as well. That's a recent publication in CMAJ from earlier this year in January. And those red flags, if you work down the list and have a look at them, and then you look at the etiologies to exclude, they're pretty significant etiology. So in safety sensitive work, for someone to say, well, present with, yeah, I have a migraine, that could be concerning if one just takes that self-diagnosis at its word and didn't actually spend any time to think about the wide list of possible other underlying pathology that one needs to rule out when thinking about migraines. Moving on, then another question in terms of safety sensitivity is it an aura? So this is another scale, the VARS Visual Aura Rating Scale. It distinguishes migraine with visual aura from other non-specific visual symptoms with 91% sensitivity, 96% specificity if the score is more than 5. And you see the scoring there, which relates to the visual symptom characteristic duration, onset, if it's a scotoma, what it looks like if it's unilateral, and just a reminder that specificity is the proportion of people that without the disease will have a negative test. So if the test is negative, they don't have it. And if it's positive, they do. So that is interesting in the paper for your references there. But those are a couple of really quick ways to score things. And it's important to rule out what all the other causes of visual stuff are. Oh, I think I had this funny transient loss of vision associated with or without a headache. So I'm not going to review the anatomy of all of the confusing and complex innervation and neural pathways related to vision, but just did want to remind you of the variety of visual defects and give you an anecdote that oftentimes, at least in my anecdotal experience of people who say they had what they thought was a migraine, and they said, but it only affected one eye. And they said they have a visual, like a lateral visual field loss in one eye. And you think to oneself, well, anatomically, that's probably not super likely. There's probably more likely than not that they had a bilateral impact, but didn't pay attention or didn't notice it because they weren't paying attention to the nasal field or something like that. So of all of those different types of field defects, the differential for all of those, again, is here. And for your reference, I know the wording is small, but pretty significant stuff to consider and to rule out if someone presents with, strange visual loss, maybe or maybe not associated with headache, and to determine whether or not, or to inadvertently assume it was an aura when it actually was not. Cerebral artery infarction, you don't want to miss that or something, right? So that brings me to the decision challenges with safety-sensitive work related to the confirmation of diagnosis. I've already alluded to that, and the identification of the most relevant factors and high-risk criteria for what would make someone in a safety-sensitive position fit to do that job, knowing that they may have a migraine and they may get auras. What would be the absolute or relative contraindications, and what are the evidence-based thresholds for that? Like, in order to allow someone to work safely without being unnecessarily conservative. And as well, the timing at which one is applying that, or is it the first time that will allow a person to embark on a career of safety sensitive work, or is this individual already safety sensitive and has a new episode of something that could be potentially disqualifying for safety sensitive work? Which brings me to the concept of risk, and recognizing that the thresholds of willingness to accept risk vary highly between individuals, which you see in this picture here. Some people feel happy enough climbing the ice, and other people feel happier staying at the bottom. As well as there are thresholds of willingness to accept risk that vary between teams and as well organizations. I work with a variety of organizations in which we do very complex single pilot fast jet operations that may be a little bit of a different risk tolerance situation than a 2-pilot commercial operation. So At this point, I'd like to show you a video to just reinforce the concept of risk tolerance and to just set the stage for thinking about safety-sensitive work and understanding the work that people do. There's no speaking with this. There's a bit of audio, but no speaking. All right. Just going to move past that and just reassure you that no injuries happened in the making of that video, but it does give you a very good sense of individuals' willingness to accept risk, and it will vary between people and organizations. So what really is risk? What are we talking about? Well, it's really a probability of something happening and the severity, and say probability of what and severity of what. Well, it's in the context of migraine, the probability is, what is the probability of an incapacitating event resulting from that migraine or a symptom recurrence or the treatment of the condition? And you could apply this to anything. It doesn't have to be migraine. It could be any medical condition in a safety sensitive environment, right? It could be a mental health situation. It could be a cardiac situation too. The probability of an incapacitating event resulting from that condition, from the symptoms, the treatment, or on-the-job exposure triggering exacerbation. And incapacitation can be subtle or sudden. It can be complete or partial. And any of those could affect work in a different and variety of ways. So thinking about examples of sudden or obvious, complete incapacitation, very easy examples of that are seizures or cardiac, and those are the ones most people think about most easily. So that's box B. But there can also be sudden and yet partial incapacitation. There can be subtle partial incapacitations, and there can be complete incapacitation that is very subtle. An example of that is hypoxia. So these are the, 3 out of the 4 boxes not to forget about when thinking about risk. And then just to remind you, risk is the probability times severity. Well, the severity of what? Now I'm bringing an aviation perspective to this. Consequences of an incapacitating medical event in 3 areas. Individual performance, obviously impact on task and safety, and the need then for immediate evacuation for medical attention. Others may define severity differently. But this is an example we use in the aviation world for air crew, but could be applied to other safety sensitive roles about, the probability and likelihood. And then once you make considerations of that, is a person fit, which is green, unfit, which is red, or you need to do some more work to figure that out, which is yellow. So now to the meat of the matter, which is what case information brings some relevant discussion point for the risk assessment for migraine. Specifically, you'll see the title is aeromedical risk, but really, to be honest, these could apply to any safety sensitive thing. So let me walk through the literature with you on the components of the migraine history that are relevant for safety sensitive risk assessment. And I've split them into three categories: a characteristic of the headache, the management of, and control, which I'm not going to spend a ton of time talking about because it's not a talk on therapeutics, and the aspects of the medical history. So first of all, the rate of onset of a headache that is a migraine can range from minutes to hours. And so that will affect one's decision about risk and safety sensitive fitness, depending on the job they do and whether or not a momentary lapse would be a critical issue. And then the frequency of attacks it can be rare occasions to daily. So this is a challenge with migraines, is that some people have rare attacks, like 10 years in between, and other people have daily headaches. And so what would be the safety threshold there? And there's a wide variation in varying organizations for the tolerance for that. Some organizations might tolerate several a month, others might tolerate none. So that will vary, and we'll go through some of the specific commentary of various organizations after I get through this section of the talk. So duration of the migraine as well. Duration, untreated or unsuccessfully treated migraines typically last 24 to about 40 hours in an unscreened general population. And if that was to occur, again, depending on the individual's role, if they're a diver, a police officer, firefighter, how much impact would that have on their ability to be ready to respond? Now, prodromal symptoms causing impairment can be fairly significant. 88% of individuals with migraine will experience impairing prodromal symptoms before they even have the headache. That's important because it prolongs the impairment period. And any of the list of impairing prodromal symptoms could have an impact or could be mistaken for other things and not attributed to the headache, which then occurs and becomes problematic. Severity, of course, is also another issue, and it's probably the most obvious one, right? The degree of incapacitation due to pain, and that can be variable, and in many situations probably likely underreported because people want to work through it. It can be compounded by the associated symptoms. So these are not the prodromal symptoms, these are the associated symptoms, which I'll talk about next. A surrogate identifier of severity, if you need to make an evaluation, is to go through the file and look at the number of visits to a care facility for treatment. And then associated symptoms, which complicate a migraine, which again is during the migraine, not the prodrome. 11% of people will have neurologic signs. So speech impairment, motor impairment, cognitive changes. These are very, very concerning for safety sensitive roles, especially in aviation, but in other ones as well. And higher risk migraines are those that are accompanied by symptoms that may impair duties and jeopardize safety. Aura. The reason I talked about aura in the beginning and put a focus on, is it an aura or is it something else, is to remind people that this is the most common characteristic for risk stratification in a variety of organizations. Higher risk migraines are those that are associated with aura, or if the aura occurs without the headache, and that's just because of the fact that it's visually disabling in a lot of cases. And the clinical presentation of aura, is it disabling? Is it not? People say, oh, well, you know, I just had a little bit of peripheral graying or a little bit of change in the blurriness in the peripheral vision. but the aura can be highly variable. Between individuals, for sure. People assume that an individual will get their own typical aura, but the literature shows that aura can vary between attacks, even in the same person. So an individual who says, oh, that, you know, my aura, it's always the same, and so therefore you make a safety sensitive decision based on the presumption that the aura will always be the same, is probably not a great idea. Most aura symptoms will develop over 5 to 20 minutes and usually last less than an hour, and most of them are visual. And that's why aura is a significant threshold decision point for many organizations. Time since the last episode, or progression versus remission is also important. So individuals that are having daily headaches or individuals that have one a year, this is a challenge with migraines, is how to predict when the next one will come. And so complete remission is really difficult to accurately identify. A lot of the studies actually will follow people for about a year, but longer follow-up times there are fewer studies with long follow-up times, but if remission is defined as migraine-free for greater than a year, 58 to 90% will not experience remission. In other words, recurrence is likely, and remission is associated with having an absence of other forms of primary headache, male sex, and absence of natural or artificial light stimulation as a trigger. So that the assumption that if you haven't had a migraine for a couple of months after your last one, you're good to go, know that 90% of people will not sustain remission for a year. So this is a slide that's USAF, stands for United States Air Force, where they will they will call an individual unfit and then will reconsider after the following criteria met. So an individual who's had a migraine aura will be unfit unless the following 3 or fewer disqualifying headaches a year, no neurologic dysfunction, deficit, or aura. So I highlight the importance of aura, mild functional impairment, if at all, and no prescription prophylactic or abortive medication is required. So in terms of the criteria and the thresholds for making decisions about safety sensitivity, the stratification points there, aura, frequency of the headache, degree of disability, and medication requirements. So all of those things are considerations for whether or not one would be fit to do safety sensitive work. And then, of course, is the issue of the triggers. 90% of migraineurs will have one or more triggers, and a lot of the reported triggers in the general population are actually unavoidable in aviation and other safety sensitive environments, and including the ones that are highlighted there in red. Like a lot of safety sensitive environments require an individual to be ready at short notice, to work long hours, to work in difficult environments. And all of those things, unfortunately, might be unavoidable. You know, if someone said to me, well, you know, I'm a pilot and my migraine is triggered by chocolate, I would say, well, don't eat chocolate. Like, that's avoidable. But if they said to me, well, my migraine is triggered by the weather, I'd be like, well, that's a bit more concerning. You can't avoid the weather. And so this is an aviation specific slide and picture, but these are just to bring to light and for those who are working with individuals doing safety sensitive jobs to take very good consideration of what the environment is that person is working with, and the compounding effect potentially of the wide variety of triggers. So I've talked a little bit about the characteristics of the headache, and I'm going to briefly talk about medication requirement and type. So there, of course, are a variety of medications available. There are the prophylactics, which themselves can have challenges related to them, because there can be a high potential for drug interactions, and they may actually have adverse effects themselves, which themselves may be disqualifying. Similarly for the abortifactants, and then pain management too. And the degree or the nature of medication required for pain management is something that is often taken into significant consideration in safety sensitive duties. Can they manage with an over-the-counter Tylenol or Advil, or do they need to go to an emergency room to seek more significant pain management? And then the last little bit for the lit review on the aeromedical or safety sensitive relevant components relates to the aspects of the medical history. So for age of onset, if the age of onset was less than 20 years, and I showed you earlier the prevalence of how that can continue to rise until the mid-30s, associated with lower remission rates and increased risk. So if someone says they had childhood migraines, that might be more concerning than an individual that developed migraines later on. Past medical history can also be relevant for comorbid conditions that are associated with greater headache severity. So comorbid restless legs is associated with greater severity, and as well, more occurrence, higher occurrence of photophobia, phonophobia, and a variety of other associated features. Comorbid insomnia is associated with, as well, greater severity, as are chronic pain disorders associated with chronicity of migraines and other associated symptoms related to the fact that they have migraines. They have an associated risk of cardiac findings as well with that. There's some thought about whether or not that might relate to the unrecognized presence of a patent foramen. And so in individuals that have really recalcitrant migraines, doing a cardiac echo may be of value in some of them. So in terms of psychosocial issues and mental health issues as well, comorbid anxiety and depression associated with a greater risk of migraine-related disability and a risk of progression from just an episodic migraine to chronic migraines if those other conditions are present. What about family history? Family history increases the likelihood of developing migraine even if one hasn't had it. So it's kind of an interesting question to ask or to understand in the family history if someone makes that declaration. It seems to me there's increasing understanding of genetic variants associated with increased susceptibility. So there is an emerging understanding of genetics related to migraines. First-degree relatives suffering from a migraine with an aura have a 4-fold increased risk of migraine, whereas those without aura only 1.9. Not only, but much less than 4-fold increase. As well, family history is associated with a younger age of migraine onset. So what about risk? You know, when we go to assess risk, uncertainty is expected. Estimates improve with time. I often ask my students, why is this? Why would an estimate improve with time in terms of our understanding of consequences and probabilities that we want to understand? And of course, that's because over time, we just continue to gather more data, get more populations that are cohorts in retrospective studies where randomized controlled trials are not relevant, build and accrue over the course of time as people gather data. So I'd like to spend the next few minutes then talking about some of the medical standards that relate to perhaps some of the safety sensitive types of trades that are working in your local community and in general. And I'd like to start with the CMAJ driving guide. There's a 9.1 edition out, and just remind you that physicians have a statutory duty to report patients who they think are unfit to drive. And I'll recognize them. Of course, there's provincial differences in it. So the reporting may be mandatory or discretionary depending on the province, but public safety supersedes some of the other concerns. So for commercial driving, or not even commercial driving, just driving in general, severe pain from causes such as I highlighted there, migraine, and a variety of other causes of pain is a concern, especially for commercial drivers, and their working conditions may prevent them from stopping. And so the pain may, even if the pain is disabling, they may have to continue. So it's listed specifically in the driving guide as a suggestion of something that would be required to report to the Ministry of Transport. Of course, requirement to report does not indicate that you have caused them to relinquish their license. It just means that somebody else will make an investigation and make that decision. So you're just indicating your concern by making such a report. As well, we talked about this and alluded to it earlier in the talk, that prescription and over-the-counter painkillers can also interfere with driving capability. So frequent chronic and incapacitating pain can be a problem, especially if self-medication is required. There are organizations that will do functional assessments for driving, just so you know that those organizations do exist. Sorry. Also in the driving guide, there's an entire section on aviation. So even though it's called a driving guide, just so that you know if pilot or commercial pilot, private pilot, a student pilot, a recreational pilot, an air traffic controller, anybody else ends up in your practice or visiting you, that this is a guide you can refer to in the section 26. So here it's not discretionary as it is with commercial driving in some jurisdictions. This is universal, that physicians are required by law to report anyone that they believe has a condition that could affect flight safety. And so reporting of the following conditions is mandatory, and there is an entire section, so I've obviously photocopied or screenshotted, sorry, the nervous system. So syncope, seizure disorder, head injury, and also headache. Migraine with aura. Remember, I repeatedly alluded to the significance of aura. And so migraine with aura is a concern and would lead to mandatory reporting. Just ICAO is the International Civil Aviation Association, did a study. This is a bit dated information now, but about like incapacitation during a flight. This is something you don't want to pay attention to as a passenger, why the pilot is incapacitated. But just say that on the list of things that incapacitate airline pilots, at least in the historical literature, headache, including migraines, sits there at the 4th most common thing. There are also medical rules for railway operators. I know there's a nice big trestle bridge there in Parry Sound. We know the rail goes through there. Safety critical positions, they're developed pursuant to the Railway Safety Act. And this act requires people that are working in those positions that are deemed safety critical to undergo periodic medical exams, and that all people who are employed in railway safety critical positions must advise their examiner that that's their role, and air crew are expected to do the same. And the Act requires that medical examiners who believe a person employed in a safety critical position that has a position that could pose a threat to railway safety must notify both the patient and the railway company. And so that is a little bit different in terms of who is getting reported to, but individual and the company is expected to be told if there is a person up in a safety critical rail position. What about commercial diving? I put the screenshot of the page and the link to the page up there. And so this is, there is an Occupational Health and Safety Act that has a regulation related to commercial diving. I copied the determination of fitness section there for you, and pointed out the blue arrow pointing to the part that says a severe migraine, particularly when complicated by aura and excessive daytime somnolence, is something to consider also in the realm of diving safety. And what about police? Now, this is just a local police piece of information from what happens in London. There may be variations, but I just give you an exemplar here of consideration for constable selection, and that any condition of the nervous system that renders an applicant medically unfit to be a professional driver would also be of concern for police. So if you have police in your practice, or police show up and require consideration, going back to that CMAJ guide, if you have no other resource to rely on, maybe a good place to start to have a look at what might be conditions of concern for folks working in policing. And what about fire? Now, I recognize the National Fire Protection Association is a US organization, although some Canadian fire departments will allude or make reference to this document. And it talks about the medical evaluation of candidates, and candidates in two different categories: medical category A, conditions that are disqualifying overtly, versus category B, that are certified as meeting medical requirements of the standard only if they can perform the essential tasks of the job without posing a safety health risk to themselves, to the other members of their team, or to the public. And so that statement is important because individuals may consider themselves not to be a risk for themselves, and they may say, well, I accept the risk. And you may have to say, that's nice, but do your members that you're working with also accept the risk that you may become incapacitated? And does the general public want you to accept that risk too? So our earlier discussion about willingness and the variation in various individuals, teams, and organizations to accept risk may have a different threshold in safety sensitivity simply than an individual wishing to say, but I'm fine and it's no big deal and let me go. And so migraine is considered to be a category B medical condition. And what that means is if an individual has a migraine, that in order to be fit for some fire departments, if they are adhering to this standard, but they may have their own based on this, they would only be fit if they can perform the essential job tasks of firefighting without posing a safety risk to themselves, to other members, or to the public. And so in general, for risk reduction, then how do we solve the problem? There's multiple points of risk reduction, and it's understanding what's happening in the general population, and having that having that literature review and having the understanding of what happens in most people who have this condition, recognizing that, you know, large numbers of people will not experience remission, that the majority of people who have aura will have a visual aura, that there's prodromal symptoms in the many cases that are incapacitating. Understanding that baseline literature is the first step. And so that's what I have brought to you today, is that literature review and understanding exactly what the epidemiology of the relevant issues related to risk and safety sensitivity are in the general population. But then there is the individual that's sitting in front of you, and that individual applicant, of course, will have to undertake a medical selection process that will be relevant for whatever trade they are, and hence also brought forward to you a variety of exemplars, and they won't be the only ones that are available. There are a variety of other standards for other trades that you may be able to seek and find for what organizations, legislators, or other writers of standards are willing to accept on a more well, it wouldn't be the individual, but does that individual, like, depending on their job, is there a standard that would be relevant for those roles? And then at that point, there is a distinction between an individual who is about to start out on a career, get trained in a career, and spend their whole life in that career, which gives a longer threshold, a longer timeline for events to occur, than someone who's trained already, and you're making an assessment of a new onset or a recurrence in someone that is already trained. So they already have certain skills. They are perhaps less likely to make mistakes as a result of incapacitation, less likely to be distracted by certain levels of discomfort, more likely to have had an opportunity to prove themselves in various scenarios, that the assessment and the willingness to enable an individual to be fit or to be accommodated with some limitations after a new onset or recurrence would be a little bit different, perhaps, in some trades, depending on if the individual is already trained. And so thinking about high levels about what is the basis of the risk decision and stratification and thresholds of disqualification for individuals with migraine, or in general, an approach is that many organizations will originally stratify by the level of training, such that the threshold is much stricter for applicants, and may be more lenient. I don't know if lenient's the right word, but have greater information available to inform the decision for trained applicants, or for trained tradespeople. Then the disability and the degree and presence or absence of aura in migraine, and thereafter also by time and the frequency of episodes, and whether or not then a period of observation would be required in order to determine whether or not they may actually successfully reach some, I guess, rather arbitrary definition of what remission might be. Can they actually make it out to a year? In the world of aviation, these periods of observation can be extensive. And by that, I mean 1 to 10 years. So period of observation is not a period of weeks, oh, you got better from your headache. If you don't have one in another couple of weeks, you're good to go, is not the kind of period of observation we're talking about for some of these conditions, especially migraine with significant aura. Anyway, With that, I will open it up to questions. I will tell you that I've provided a bunch of recommended readings for you, and I think eventually my slides will be available if you want to make reference back to them. And I will open the floor. I think we have a few minutes anyway for questions and discussion. I'd be interested to hear actually if anyone has any safety sensitive individuals working with you locally. I'd be interested to hear, so it's sort of me asking you the question, I guess, your approach to this, because you know, it's good for me to understand how these things are being approached in other trades. I come primarily from an aviation perspective. Anyway, I'll open the floor.
If anyone has any questions, just go ahead and unmute yourself and ask. Not seeing anything. Nothing's coming up in the chat.
Yeah. I'm going to see if there are other additional slides that I have that might be of interest. I do have a couple of extra slides that show approach to safety sensitivity. I don't want to belabor the point, but just tell you that those slides will be in my slide deck when you get them, if you are in a position where you have to make a comment. And then there's a question of the session is being recorded, I believe, yes.
I'm just wondering, from a healthcare perspective, is there any, I've never seen it for healthcare providers and migraines.
So any documentation, you mean, or any standards?
Well, yeah, any standards, restrictions.
I don't know. I haven't seen any. I'm not sure that healthcare providers are typically deemed to be safety sensitive. I think you can argue that in a variety of ways, and depending on what their location, their geography, and the work they're doing is. But it's not the same scenario as trades that are that have a legislative framework around it. So there the safety sensitivity of some trades has at least some legislation related to it. So driving will, diving will, air will have regulatory compliance, whereas other trades that are deemed safety sensitive that don't have that would be deemed so primarily probably by the employer. So there may be employer specific special discussion, or maybe there's a local provider that's making decisions about fitness to work or to return to work. But whether or not that specifically deems the individual to be safety sensitive, less so. Now, admittedly, migraines occur in a lot of people and they don't all have safety sensitive roles. So the question is then, is really the discussion more related to fitness to return to work and fitness to return to their job, safety sensitive or not? Part of that, I think, in those roles, really significant consideration of how well the symptoms can be managed, whether or not those people are in a position to be working completely alone, or whether or not they have coverage if something should happen. Is it a two-person operation, or are you just the sole person there? Are pretty significant considerations for individuals. You know, often folks are working in a team or multi-person environment. If one person began to feel unwell, others could pick up the slack, so to speak, particularly if the frequency of that occurrence was, you know, relatively rare. And that could occur for a variety of other issues as well, be it, you know, bowel issues or circadian disruption or whatever, right? So I've been babbling. I don't know if I really answered your question, which I think the generic answer to your question is probably no. I haven't seen any specifically for healthcare.
Yeah, it's hard to answer if there's no real standards, but I'd hate to have a surgeon operating who suddenly becomes incapacitated.
Yeah, that would be a challenge. That's for sure. And then there's that process of risk assessment, which goes into, and the considerations for the risk assessment, which I'll move the slides forward again. The process for that, and I think this is a good one, determining medical fitness for migraine. Assessor consideration of all the factors, right? How the prodrome, how bad is it? The precipitating factors, and are they controllable? Or the triggers, the aura, whether there is one, and if there is one, if it's perimeter versus central scotoma, how quickly the onset tends to be, the frequency, severity, and the type of medication, and if that medication actually works. Is another consideration. So all of those things, which mean that the risk assessment for migraine has to take into a lot of factors to determine whether or not an individual would or would not be fit. There's just so many variables. That's why a huge and well-detailed history is relevant for anyone that has migraines that is, returning to work or at risk for having incidents from subtle or sudden incapacitation in their workplace.
Are there any other questions? Hearing none, I'd like to thank Dr. Sari for giving this very informative presentation today. I certainly learned a lot. I hadn't considered how it would affect certain industries. So thank you very much for that. And I hope we can invite you back at some time in the next year or so to give us another talk.
Yeah, for sure. I like speaking with this community because I have a special relationship with West Perry Sound Health Center. So thanks for continuing to invite me back year after year. I do enjoy coming. I just hope I can have enough new information to keep presenting to you that is of interest. Alternatively, I'm going to present to you my talk on how to make maple syrup.
For sure, for sure. Maple syrup's always a favorite in this community.
Yeah.